And we would like to start by inviting our first speaker, who happens to be my co-chair, to take the podium, and Julia will be speaking on the impact of 2 annual cycles of mass drug administration on temporal trends of clinical malaria. Thank you, Julia.
Good evening once again. I'm presenting results from a study in the Gambia that has looked at the impact of over 2 years of 1 annual round of mass drug administration with dihydroartemisinin piperacin. So in the last 2 decades, the Gambia has implemented several malaria control interventions that have resulted in a decline of malaria morbidity and mortality. There is early detection and treatment of clinical cases. We've had annual nationwide distribution of bed nets since 2006, and every year we have indoor residual spraying that started in 2009, and recently in 2014, seasonal malaria chemoprevention for children under 5 years of age. However, even with all these multiple control interventions, we still have residual malaria transmission going on in certain regions of the country. So mass drug administration, that I'll refer to as MDA, may reduce asymptomatic carriage and in turn reduce the transmission of malaria in this country. So the objective of this study was to assess if 1 round of MDA with dihydroartemisinin piperacin, that I'll refer to as DP, will observe an impact on the human reservoir of infection and in turn a reduction in malaria transmission. This study was conducted in 5 regions of the country, both on the North Bank and on the South Bank. We had 6 pairs of villages, and it was conducted from 2013 to 2015. In 2013, that was our baseline year, where we had monthly surveys conducted in these villages between June and December, and then once in the dry season of 2014. So in 2014 and 2015, after each round of mass drug administration, we went back to the same communities and conducted these monthly surveys from June to December. We detected clinical malaria by passive case detection in the villages and also in the surrounding health facilities. For the MDA specifically, we included all the residents in these villages that were over 6 months at the time of enrollment in 2013, and they should have been resident in the villages for at least 6 months and should have provided consent or assent, respectively. We excluded the pregnant women, and we ensured that they had received sulfadoxine pyrimethamine for the intermittent preventive treatment. The infants less than 5 kilograms were excluded, and the elderly participants over 75 years old. However, for the monthly surveys subsequently, we still collected samples from them. So all our doses were given by weight-based administration. We administered them by direct observed therapy, and then we monitored the adverse events passively for the first 28 days after MDA by the nurses who were resident in these villages. So a summary of our results. In 2014, we had over 4,321 participants in the cohort. Of these, 14.4% were not screened, and the main reason was because they were either away from the village or they refused to participate in the MDA, so 21.5% declined to participate. So that left us with 3,691 people who we screened for the exercise, and we excluded a further 4.3%, mainly due to pregnancy. Only 1 child was less than 5 kilograms. So in 2014, we administered 3,506 DP doses, giving us a coverage of 81.3%. In 2016, we had 4,236. Of those, we did not screen 862, which is 20.3%. So we had more individuals who were away from the village in 2015, and a higher proportion of individuals who declined to participate in the MDA, which was 30%. So we ended up screening 3,374, which is 79.7%. Of those, we excluded 4.1%, and we ended up administering 3,198 doses, giving us a coverage of 75.5%. So this cohort, at the time of enrollment, the majority, 53.9%, were female. The median age was 12 years old, and bednet ownership was high at 70.6%. Over the 3 years of follow-up, bednet use remained high, so it was 73.4% in 2013, 81.9% in 2014, and 78.7% in 2015. Looking at the coverage and compliance of DP over the 2 years, so in 2014, our coverage of the 3 doses was 68.2%, compared to 65.6% in 2015. Coverage of the 2 doses was similar in both years, 8.4% versus 7.5%, and only 4.7% took 1 dose in 2014, and a smaller proportion in 2015, which was 2.8%. So our goal in 2015 was not only to improve the coverage, but the compliance to the 3 doses, and we were happy that more people completed the 3 doses. When you look at the coverage of the 3 doses across the villages, overall, most of the villages had a coverage of over 70%, with the exception of 3 villages where we had a coverage of less than 60% for both years. This slide is summarizing the prevalence of malaria infections and incidence of clinical disease in 2013 and 2014. So in 2013, we observed a prevalence of malaria infection in the western and central regions of the country. Prevalence of malaria infection was about 5%, and in the eastern regions of the country, prevalence of malaria was as high as 40%. After 1 year of MDA so with this high prevalence, this transected the country into 2 regions. So we had low prevalence of malaria infection in the eastern central regions of the country, and moderate to high transmission in the eastern region of the country, transecting the country into high and low malaria transmission. So in 2014, after the MDA, we clearly saw a reduction in the incidence and prevalence of malaria infection in the low transmission sites, but also similarly in the high transmission sites. Okay. Sorry.
It's not moving forward?
No. Oh, good. Sorry. After the second round of MDA in 2015, we observed that in the sites with low transmission, that is on the North Bank and in the Western region, the incidence of clinical malaria declined significantly even after the second round of DP. However, in the Eastern region, we observed only a brief reduction in incidence of clinical malaria in the first 2 months after DP administration, and thereafter the incidence returned to baseline rates in 2013. Okay. Oh.
Are there any animations?
Mm-mm. Sorry. Okay. So we further looked at the risk of clinical malaria among individuals that were infected in the dry season preceding mass drug administration. So the multivariate analysis that adjusted for age and gender showed that individuals who were infected with malaria infection in the dry season before MDA had a 2 times increased odds of developing clinical malaria after the mass drug administration. Similarly, the children between 6 to 17 years old had a 2 times increased odds of clinical malaria compared to the younger children under 5 years old. However, the females had 40% reduced odds of infection in the transmission after MDA compared to the males. We then looked at the overall risk of clinical malaria after the 2 years of mass drug administration. The multivariate analysis model showed that individuals who took at least 1 dose of DP had a 24% reduced odds of acquiring clinical malaria after the 2 annual cycles compared to individuals that didn't take any treatment. Similarly, the females had a 21% reduced odds of infection compared to the males, and the older children still had a 59% increased odds of infection after taking DP compared to the children under 5 years old. So in summary, after 2 annual cycles of MDA, this study has shown that we had a coverage of over 70% and a very high compliance of over 80% in both years. MDA had a temporal effect on malaria prevalence and incidence of clinical disease. There was, however, a higher risk of clinical malaria in individuals infected during the previous dry season, and 1 year of MDA also reduced the individual risk of clinical malaria. However, in a setting like Gambia, we think that we need several MDA rounds to achieve a greater impact on incidence of clinical malaria. So I'd like to thank the funders of this study, the Medical Research Council of the UK. We work in partnership with the National Malaria Control Program of the Gambia. Very grateful to our study team members, the MRC team, the Laboratory and Statistics Department. But to achieve the high coverage, we worked very closely with the community health workers, the village leaders, and our study participants. So thank you very much.
Thank you very much, Julia. We can now take some questions. If you have a question, please come to one of the 2 microphones in the aisles.
Abdullah from Zanzibar, Malaria Elimination Program. Thank you very much for presentation, very informative. I just want to be technically informed on programmatic implementation of the MDA. A case of Gambia, you need more than 1 or 2 or 3 rounds. You just mentioned several. How many are you anticipating to put in place? But looking at the different studies, there are annual cycle of MDAs. We have other places where 2 cycles are being implemented. What actually is supposed to be put in place to ensure that we halt the transmission in foci areas? Should it be 1 or 2 or 3? Can you give some comment on this? Thank you.
Thank you very much for your question. In a setting like the Gambia, what the data clearly shows that if you're in a very low transmission setting, the 1 annual cycle can actually significantly reduce your incidence of clinical disease or malaria infection. If you're in a setting with moderate or high malaria transmission, 1 cycle is not clearly not sufficient. You would need a 2nd cycle. So we administer the MDA at the start of the malaria transmission season, but we think we actually need a 2nd cycle in the middle of the transmission season to keep the pressure off the parasite. So maybe 2 or 3, depending on the transmission setting that you're in.
Thank you.
Hi, Leopoldo Villegas, based here in Washington, D.C. Thank you for the presentation. Just wanted to ask you if you can comment on the gametocytemia before you start the MDA, the use of primaquine, and I think that is very important in this setting, especially with the low transmission. Thank you.
So this study did not collect data on gametocytemia. It was mainly just on the parasitemia, overall parasitemia. But I know other studies in the Gambia have shown that you probably need to add primaquine into the DP or whichever drug you're using for the MDA to actually clear the gametocytemia. I hope I've answered your question.